Welcome to the deep dive. Today we are looking at a fascinating and frankly, quite fragile intersection in our modern world.
We really are.
Yeah, we are talking about our rapidly aging population, the heavy, often invisible burdens of caregiving, and a massive escalating threat that is, well, it's hiding in plain sight. Antimicrobial resistance, or AMR.
Right.
If you are a pharmacist, a doctor, a public health leader, or honestly, if you've ever just worried about caring for an aging parent or wondered why a simple trip to the pharmacy feels increasingly fraught with anxiety, you are going to want to hear this.
Absolutely. And our mission for this deep dive is to synthesize a massive stack of sources for you. We are pulling from demographic studies, financial gerontology reports, legal documents, medical journals, and even the latest in AI healthcare innovations.
It's a lot of material.
It is, but the goal is to deeply understand how a very human emotion, fear, is actually driving a global healthcare crisis, and how new frontline triage tools might be the key to empowering us and protecting our most vulnerable.
Okay, let's unpack this, starting with the demographic reality we are all living in. I mean, we all know the population is aging.
Yeah, the stats say the global population over 65 is projected to jump from 6.9% to over 15.6% in the coming decades.
Right, but what that actually looks like on the ground isn't just, more retirement communities. It is a fundamental rewiring of who does the heavy lifting in our society. If you're listening to this in your 40s or 50s, you are likely the one doing that lifting.
You are. And practically speaking, this demographic shift entirely changes the landscape of healthcare. Old age brings a significant rise in multimorbidity.
Which means managing 3 or more chronic conditions simultaneously, right?
Exactly. We see physical changes like declining fine motor skills, changes in gait, an overall increase in frailty, and slower reaction times. And there is a really compelling twist in the data here. Despite these physical declines, studies actually show that older adults are generally a happier age group than younger people.
See, that is such an interesting paradox. Research from Buffalo and Northwestern universities back that up, too. The elderly might be happier, but I have to imagine the people caring for them are under immense pressure.
Oh, without a doubt.
We hear a lot about the sandwich generation. According to the Pew Research Center, 47% of middle-aged adults are currently in that bracket. That means you are caring for an aging parent while simultaneously raising a young child or financially supporting a grown child.
And the Pew study highlighted a wild contradiction there.
Yeah, 73% of these middle-aged adults provide financial help to their grown children, yet society places a much higher moral expectation on supporting elderly parents. Like, 75% of people believe that elder care is a fundamental responsibility. It's a bizarre cultural cognitive dissonance.
It really is. We are morally hardwired by society to support our aging parents, yet we are economically forced to continually bail out our adult children. It means the middle-aged caregiver is acting as a dual-facing ATM, both emotionally and financially.
And this isn't a brand new phenomenon.
No, not at all. But the intensity is unprecedented. If we look back to the 1950s, researcher Peter Townsend interviewed working-class families in East London and identified what he called the strain of illness in caregivers. Today, that strain manifests as massive presenteeism in the workplace.
Let's define that for a second. Presenteeism isn't just showing up to work. It's when you are physically sitting at your desk, but you are so mentally exhausted or distracted by caregiving duties that your productivity just plummets.
That is spot on. You are there, but you aren't really there. The psychological toll is heavy, but the financial complexities are what often break families. Caregivers have to navigate an absolute labyrinth of institutional rules.
But surely there are safety nets. I mean, in the U.S., we have Medicare and Medicaid to catch people when they fall.
You would think so, but the mechanical reality of those systems is brutal. Medicare doesn't cover long-term custodial care. So, to qualify for Medicaid, which does, families are often forced into what is called a spend-down. This means an elderly person literally has to impoverish themselves, draining their life savings, liquidating assets just to legally qualify for the aid they desperately need.
It's heartbreaking.
It is. And while caregivers are managing that bureaucratic nightmare, they also have to act as security guards against the severe risks of financial exploitation. They are constantly monitoring accounts for unfamiliar credit charges, tracking missing mail, or fighting medical providers who are billing for services the senior never even used.
The cultural ripple effects of this burden are profound across the globe, too. Our sources highlighted the extreme pressures of China's one-child policy. Because the hopes and the absolute entirety of caregiving duties are vested in just one single child, the pressure is immense.
Yeah, the sources note that in some Chinese villages, they actually publicly shame those who neglect their elders.
Imagine walking through your hometown and seeing a public notice board explicitly calling out individuals for failing to visit or support their parents. Is a harsh way to enforce compliance.
Extremely harsh.
On the flip side of the globe, we have what is called transnational caregiving, which creates this massive, heartbreaking emotional vacuum.
You have families trying to provide financial and emotional support across oceans. Imagine the anxiety of a patchy 3 a.m. Zoom call, trying to understand a complex medical diagnosis from a doctor thousands of miles away.
Right, because these families are navigating strict immigration policies that prevent them from bringing their parents over, while dealing with a severe lack of institutional care back in their home countries.
But technology is finally starting to step in to bridge that gap.
Yeah.
We are seeing transnational care providers utilizing telemedicine networks like MedInexo to connect specialists globally. There are smart digital pill dispensers that alert family members if a dose is missed.
And incredibly, there are now machine learning models using data from simple wearable accelerometers like smartwatches to predict cognitive decline in older adults just by tracking subtle, long-term changes in their daily movement patterns.
Those technological advancements are vital. However, they run into a massive behavioral roadblock. When an aging parent, or even a child for that matter, gets sick, our immediate, deeply ingrained instinct is not to check an app. It is to seek immediate medical help, to go straight to the hospital or the clinic.
Right.
And our sources reveal that a huge portion of our modern healthcare crisis is driven by this single behavioral problem: fear.
Let's dig into that because it sounds counterintuitive. Shouldn't we be afraid of getting sick? I mean, if you're a public health professional listening to this, you want people to take illness seriously.
To a degree, yes, but we have to look at the neuroscience. The amygdala, the brain's fear center, activates long before any rational evaluation of the symptoms can occur. Crucially, the brain cannot distinguish between a real, life-threatening emergency and an imagined fear.
Wow.
So when that thought spiral starts, say, your parent develops a sudden cough, the body reacts instantly, heart rate rises, palms sweat, and you might even experience abdominal pain or tingling fingers from hyperventilation.
And the crazy part is that stress response actually suppresses the immune system, making the person even more vulnerable to the very infection they are terrified of.
Exactly. The behavioral result is that people rush to the emergency room or the pharmacy for what are often completely self-limiting or viral symptoms. We are talking about a standard cough, a low-grade fever, a sore throat, minor wounds, or a stomach upset.
Things that usually clear up on their own.
Right. But they arrive driven by fear, fully expecting and often demanding a prescription for antibiotics. In the United States alone, studies estimate that 30 to 40% of emergency department visits are completely non-urgent.
That fear-driven rush to the hospital strips the elderly of their autonomy, too. We see aging parents actively hiding their failing health from their kids because they're terrified of becoming a burden or terrified of being forced into a facility.
It's a vicious cycle.
It is. And when they do enter the hospital system, it often strips away their little freedoms, choosing what they eat, deciding when they sleep, or just wearing their own clothes. That sudden loss of autonomy directly leads to increased anxiety, depression, and a tragic loss of personal identity.
The systemic fallout from this fear is that hospitals become completely overloaded, and the practice of medicine becomes entirely defensive. Overprescribing of antibiotics happens not just because anxious patients demand them, but because there are intense systemic pressures on doctors and pharmacists to process patients quickly, clear the waiting rooms, and protect themselves legally.
Our sources detail a major legal controversy in the UK that highlights this tension perfectly. It's the case of Srivatsa v. Secretary of State. Impartially speaking, the UK government wanted to increase public access to medications and ease the burden on doctors. To do this, they extended virtually unlimited prescribing powers to nurses and pharmacists.
Right. And doctors, including Dr. Srivatsa, legally challenged this move. Their argument was that allowing professionals without full medical diagnostic training to prescribe could be incredibly dangerous.
Right, because diagnosing without that 5 or 6 years of rigorous medical training inevitably leads to misdiagnosis, missed complications, and the massive abuse of antibiotics.
It places an immense burden on those frontline workers. Pharmacists and nurses are suddenly tasked with distinguishing between a minor viral illness and a life-threatening infection, with the severe legal and clinical risk falling squarely on their shoulders.
Here's where it gets really interesting, and honestly, this is the most critical part of our deep dive. This fear-driven rush to overloaded hospitals and clinics is feeding an invisible, escalating threat hiding right inside those very buildings. Antimicrobial resistance, or AMR.
AMR is arguably the slow-motion crisis of our time. And if you're a policymaker or a doctor listening right now, the evidence presented in these documents is stark. Antimicrobial resistance is already approaching approximately 42% worldwide.
42%, that is terrifying.
And projections suggest we could see around 52% resistance by 2028. Currently, AMR is responsible for over 1.2 million direct deaths annually. If we do not radically change our trajectory, that number is projected to hit 10 million deaths annually by 2050.
Wait, there was a statistic in the sources about India that stopped me in my tracks. It noted that 83% of people in Indian hospitals, including the staff, are currently colonized with AMR bacteria. Can we clarify that for a second? When you say colonized, does that mean 83% of people in those hospitals are actively sick with a superbug, or just that they are carrying it?
That is a vital distinction. Being colonized means you are carrying the bacteria on your skin or in your gut harmlessly. You are not actively sick or infected by it.
Okay.
But in a hospital setting, widespread colonization is a ticking time bomb. It means the superbugs are everywhere. The moment a vulnerable person gets a cut, has a catheter inserted, or undergoes surgery, that harmless colonizing bacteria can enter the bloodstream and become a fatal, untreatable infection.
So what does this actually mean for modern medicine? Like, what happens if this hits that 52% projection by 2028?
It means the collapse of routine medical achievements that we completely take for granted. Almost all of modern medicine relies on effective antibiotics as a safety net.
Right, so we are talking about cesarean sections, joint replacement surgeries, organ transplants, cancer chemotherapy, intensive care medicine, and even minor wound and trauma care.
Yes, these procedures all suppress the immune system or open the body to infection. Without effective antibiotics to prevent or treat secondary infections, a simple scrape or a routine hip replacement becomes incredibly dangerous, if not a death sentence.
And AMR isn't just contained within hospital walls. It has a massive environmental angle. Data from India and our sources shows how untreated sewage, open defecation, and agricultural manure and sludge that are absolutely laden with antibiotics from the livestock industry are breeding superbugs in the soil and water.
The collection of antibiotic-resistant genes persists and multiplies in the environment. This directly threatens manual workers and farmers. Imagine a farmer getting a minor cut or a standard respiratory infection from their occupational environment, only to find out it is an untreatable superbug.
The consequences for our food supply, occupational safety, and global stability are severe. Yet despite this massive existential threat, the pharmaceutical pipeline for new antibiotics is practically empty. Why aren't we just pouring money into making new ones?
We are facing the empty pipeline problem. Since July 2017, only 13 new antibiotics have received marketing authorization. Pharmaceutical companies face a brutal economic paradox here. Developing a new drug costs billions of dollars. But to prevent bacteria from developing resistance to a new antibiotic, public health mandates require that doctors use it very sparingly, reserving it only as an absolute last resort.
That means incredibly low sales volume.
Which leads straight to bankruptcy for the very companies innovating the drugs. To combat this, organizations like CARBX are funding early-stage research, and governments are exploring subscription-based payment models.
How does that work?
It would decouple the drug's revenue from its sales volume, essentially paying the pharmaceutical company a flat fee for the availability of the drug rather than how many pills they actually sell.
Okay, let's connect the dots here. If hospitals are high-risk zones colonized by superbugs and our antibiotics are failing, the ultimate goal has to be keeping people out of the hospital entirely, unless it is a genuine life-threatening emergency.
What's fascinating here is the emergence of community-level triage as the absolute frontline gatekeeper. If we can manage the public's fear at the community level, we can solve a massive part of this puzzle. Pharmacists and chemists are the true first line of healthcare.
Yeah, people almost always visit pharmacies before consulting a doctor.
Right. And as we discussed, pharmacists face the incredibly challenging task of distinguishing a minor illness from a potential infection, deciding when reassurance is enough, and knowing when to recommend medical consultation, all while avoiding inappropriate antibiotic dispensing.
And that is where the Prema system comes in. Prema stands for Personal Risk Evaluation and Mental Assurance, alongside MEA, which is Medical Advice You Access. These concepts, developed by Dr. Kadiyali Srivatsa, are designed to sit right at that front line.
They are community triage and reassurance tools. And the way they function is a massive leap forward. Instead of using rigid robotic algorithms like a standard web search that just tells everyone with a headache to go to the ER to avoid legal liability, Prema uses what's called symptom pattern reasoning.
Let's break that down because it is so different from what we are used to. How does symptom pattern reasoning actually work?
It assesses combinations of symptoms rather than isolating them. It functions very much like the brain of an experienced doctor. For example, a cough plus a low fever means one thing, but a cough, a high fever, and a specific type of chest pain means another.
So it's looking at the whole picture.
Exactly. The aim is to help distinguish clearly between a minor illness, a moderate health issue, a potential infection, and actual emergency symptoms.
The benefits of this for the post-antibiotic era are profound. First and foremost, these triage kiosks act as fear management tools. They reassure you, the patient, when you just have a minor viral issue. It gives people the confidence to stay home, drink fluids, and rest, rather than demanding a pill that won't help them anyway.
And by managing that fear, it directly eases the pressure on pharmacists and doctors. Pharmacies equipped with triage tools like the Prema kiosk can become the true community health gatekeepers.
Which protects the pharmacists.
Yes. It protects pharmacists from clinical risk because they are guided by an advanced, patient-centered assessment. It empowers the public with a better understanding of their symptoms, reduces unnecessary antibiotic misuse, identifies serious illnesses much earlier, and ensures that hospitals are strictly reserved for the critically ill.
So, what does this all mean? Let's take a couple of minutes to really summarize this crisis and the importance of this community-level triage. Because whether you are a public health professional drafting policy, a doctor feeling the strain of defensive medicine, a pharmacist standing at the counter, or just a part of the sandwich generation feeling the crush of caring for an aging parent, the message from our sources is clear.
It really is.
We have to fundamentally shift away from a fear-driven, hospital-dependent mindset. The projection of 52% AMR by 2028 isn't just a number. It's a warning that the foundations of modern medicine are at risk. We need to move toward an empowered, patient-centered approach, embracing community-level early assessment tools like Prema, supporting our frontline pharmacists, improving our infection awareness, and fiercely protecting the antibiotics we have left is how we adapt and survive the post-antibiotic era.
It requires a complete paradigm shift in how we view sickness and care. And connecting all of this leaves us with one final, incredibly important frontier to consider. We've seen how AI and wearable tech can monitor physical symptoms and predict cognitive decline in the elderly. We have seen how AI-driven triage tools like Prema can manage our fear of physical illnesses and protect our antibiotic supply.
Right.
But as the sandwich generation faces truly unprecedented emotional and financial strain, could the next evolution in healthcare technology be an AI specifically designed to monitor the caregivers themselves?
Oh.
Imagine a system capable of detecting the subtle biometric markers, the vocal patterns, the specific sleep disruptions, the micro changes in daily routine that signal severe compassion fatigue. A system that could step in to intervene, offering resources or respite before the caregiver's own physical and mental health completely collapses.
An AI to care for the caregivers. That is a deeply powerful thought to mull over, especially for anyone currently feeling the weight of that responsibility on their shoulders. Thank you so much for joining us on this deep dive. It's been an incredible journey through the data, the demographics, and the future of community medicine. We hope it's given you a new perspective on your health, your family, and the tools we need to protect our future. Until next time, take care of yourselves.